Selamat sore, ya. Selamat sore semua.
Selamat sore.
Saya sudah standby sejak tadi loh, jam 1. Tapi seperti biasanya jam 1. Jam 2 ya, dimulai jam 2 ya.
Ya dok, soalnya dengan Rusia, jadi menyesuaikan jadwalnya mereka.
Oh,
Kalau ada satu pertanyaan, apa sebenarnya bioetika itu? Bioetika itu berkembang dari waktu ke waktu. Yang tadinya etika menjadi biomedical ethics, oleh karena yang banyak menggunakan etika itu kedokteran, medical tadi. Namun demikian sebenarnya pada saat ini yang tidak etis itu tidak hanya kedokteran saja, bisa terjadi di hampir semua bidang ilmu. Sehingga dengan demikian dari biomedical ethics tadi berkembang menjadi bioetika, kemudian global bioethics, ya. Dan yang terakhir yang kita kembangkan di sini, apa yang kita sebut dengan the new sense of bioethics. Ini pun saya mengembangkan ini distimulasi oleh sekretaris UNESCO yang di Paris. Pertanyaannya, Narto, kamu punya Pancasila, tolong etika itu dikembangkan ini. The new sense of bioethics itu adalah satu studi dari transdisciplinary subject, biologi dan seterusnya, ya. Ada sosiologi, ada economics, ada politics, language, bahkan arts, and is studying of human behavior untuk memiliki in having a new tolerance on transdisciplinary attitude. Apa itu artinya? Memang ada keterangan lebih lanjut, tapi itu setidak-tidaknya batasan dari new sense of ethics. Tadinya itu respect for person, beneficence, dan justice. 3. Berkembang menjadi 4. Respect for autonomy, beneficence, non-maleficence, dan justice. Nah, dengan the new sense of ethics ini, respect for others itu berarti respect pada antar orang dengan hewan, antar orang dengan tumbuh-tumbuhan maupun lingkungan. Ya, jadi dengan demikian respect for others itu ada artinya tersendiri, berkembang lagi. Beneficent, non-maleficent, yang kita tambahkan di situ adalah tidak hanya justice, tetapi it should be social justice for all. Itulah Pancasila.
Center for Bioethics and Medical Humanity atau CBMH merupakan bagian dari Fakultas Kedokteran, Kesehatan Masyarakat dan Keperawatan Universitas Gadjah Mada. Sebagai bagian dari perguruan tinggi ini, kami mengemban tanggung jawab untuk melaksanakan Tridharma perguruan tinggi. Kolaborasi nasional dan internasional merupakan kunci dalam melaksanakan Tridharma tersebut. Melalui kolaborasi ini pula, CBMH dapat bertransformasi menjadi sebuah pusat pengembangan ilmu bioetika dan humaniora kedokteran dan membidani lahirnya program Master Bioetika.
Good afternoon, ladies and gentlemen. Good afternoon, everyone. It's afternoon here in Indonesia, Jogja. Maybe it's good morning in Russia. Okay, so first of all, I would like to welcome everyone here to our weekly bioethics forum. We're doing this online every Wednesday. And for this special occasion today, we're going to have our session in collaboration as part of the collaboration program with our newfound partnership with ITMO University from Russia. Hence the title of the weekly Wednesday today is collaboration between our Center, Bioethics and Medical Humanities at UGM Indonesia with ITMO University. So this is a very new partnership, but we are so hopeful that we found common interest to develop and explore further, especially about the topic of public health ethics. So we do hope this first collaboration webinar today is going to be a start, an initiative for a continuous future collaboration with our partners at ITMO University. So I think before we start our talk and our session with our speakers today, maybe I would like to say hi, greetings to our ITMO friends from Russia. And I apologize if I pronounce your name incorrectly. I'm trying, so please correct me and teach me. I think we have Sinia here. Hello, good
Hello.
morning, Sinia.
Morning. So
Yes.
it is 10 a.m. Russia.
Yes, it's 10 a.m. It's pretty early there for Russia.
Well, it's not that early, it's just really dark.
Okay, so it's 2 p.m. here in Jogja, Indonesia. So it's past lunchtime. And I see some other names from ITMO Russia. We have Irina. I think we have Anton as well. So I would like to invite maybe Sinia or other would like to maybe say a short greetings.
Yes, of course. I'm not sure if Anton is here with us today. He told me he was traveling to the Netherlands at the time, so he unfortunately couldn't be able to join to greet everyone. But I think I'm here to do such a thing. It's my pleasure and my honor. Hello, everyone. My name is Ksenia Spiridonova. I'm working at my university in St. Petersburg, Russia, at the program where we're doing for 3 years now. We're doing the program in public health sciences, which for us still quite an experimental format, something that we're still looking for the best solutions and the best practices all over the world. Of course, one of our goals, and it was like this from the very beginning, to collaborate and to look for new partners, professors, students, exchange students, whatever, you name it. I'm very happy to see my students and my alumni here with us today. I'm sorry if I'm missing someone, but I see Irina, Artemi, Nika, Oksana, Anton, Anton I'm seeing today is our student. Actually, it's not the head of the program. Also, Irina Gorbunova, and maybe I'm forgetting something. I'm very sorry. I'm really glad that you found the time and found your interest in bioethics. And I also want to say that we experienced, like our colleagues from Indonesia know, that we experienced some difficulties in terms of finding the perfect professor and like really tailor the course in bioethics, and we're still like looking for options and for possibilities there. And we were really happy to find you, your center, and the initiatives you're doing there, because we believe, like hugely believe, that it would be very, very beneficial for staff and students and alumni. So we're really happy. Thank you very much to welcome us.
Okay, thank you, Zinia, for representing the ITMO University, and also greetings to all of the teams and maybe students, colleagues, faculty from the ITMO University. So yeah, I'm going to echo what Zinia has mentioned, that it is a really exciting opportunity for us as well. We are looking forward for further more collaborations, and I think this is a good start. We do hope we can have a fruitful discussion today, even though for this session today, we're going to start sharing from our part, but we believe after this, we have another series for webinar, so then we can also learn from your part, your experience from the ITMO University representing Russia. So yeah, we're so happy. And oh yeah, maybe I forgot to introduce myself. My name is Wika. I'm going to moderate the session today. On behalf of the Center for Bioethics and Humanities from Gajah Mada University. So I'm here on behalf of the center as well, and we are also welcoming our speakers today. We have 3 speakers from our center today that is already joining with us. We have Professor Muhammad Hakimi, and we have Professor Yayi Suryo Prabandari, and we have also Dr. Tiwi Agnes Bhakti Pratiwi with us today. So we do our audience from Indonesia. So we have regular audience from Indonesia, from our master students, bioethics master students, and also other colleagues who are interested and partners have been partnering with us, the bioethics in Indonesia. So welcome to everyone. And I do apologize because it's raining quite hard here in Jogja right now. So I do hope the internet connection would not be affected too badly. But if there is any glitch, maybe it's because of the rain. It's raining heavy right now behind me. Okay. So without further ado, I would like to maybe straight go introducing our speaker today. So we do have our main topics for the series webinar in collaboration with ITMO on the aspect and the area of public health ethics, because I think that's the common interest that we would like to explore together. And so for today's session, we're going to focus on addressing the challenges of public health ethics practice, maybe from the Indonesian perspective for today. And then we will be continuing the series, sharing learning as well from the Russian perspective. And so for today, we have Professor Hakimi, and Professor Hakimi is going to convey the speak on introduction to ethics in public health, the importance, how public health ethics is important in the practice and public health practices. And then we will have 2 case studies discussed about how public health ethics is implemented. The one is in the area of primary health care. Maybe more specifically, Dr. Agnes is going to talk about privacy. And then Prof. Yayi is going to talk about case study, how ethics is implemented if it's in the context of tobacco control and smoking cessation services. So we will have roughly 20 minutes for each of our speakers, and then after that we will be discussing together. So if audience, you feel like you will have, you will want to comment or maybe ask question, we will have that opportunity after speaker finishes the presentation, or you can also type in the chat. We will collect the questions and the comments, and we will bring it up during the discussion session. So without further ado, I think we will go straight to Prof. Hakimi. Maybe the committee would like to share screen a little bit about the CV so that others, especially the ITMO friends, can also see Prof. Hakimi's screen. Would you like to share the screen? So I will briefly introduce Prof. Hakimi. For us in Indonesia, he's a well-known faculty, but I know we need to introduce to our friends at ITMO University. So Prof. Hakimi, he's a professor, already retired, but still very active, very much active, especially in bioethics and also in evidence-based medicine. So he's a professor in obstetric and gynecologist, and also fellow in clinical epidemiology and biostatistics, and has been very supportive and very active in our Center for Bioethics, Clinical Ethics, and also Public Health Ethics. Prof. Hakimi is also a member and prior chair of the Research Ethics Committee at our Faculty of Medicine, and also the member of the Academic Standard Committee for PhD program, and also consultant for master degree program in midwifery at in Yogyakarta, in one of the Universitas Aisyah Yogyakarta. So without further ado, we would like to invite Prof. Hakimi to share the expertise and the talk about the importance of ethics in public health practice. Prof. Hakimi, time is yours. We have roughly 20 minutes. Yes, I think the screen is up. Yep.
Okay, thank you very much, Vika, for the introduction. And good afternoon, our colleagues, either from Indonesia and from, I think, ITMO University is in St. Petersburg, in Russia.
Yes, in St. Petersburg, Russia. Yes.
I think it's almost on the other side of the world. Yeah.
Yes, then the flip of the globe.
Yeah, it's nice to have you with us today. When I will talk about the importance and needs for ethics in public health. And first, we will look at the what is ethics, and then of course what is public health ethics, and then we will look at the frameworks for public health ethics, introduce challenges in public health ethics, and we also will look at the difference between public health ethics and bioethics. Yeah. I think there's important difference that we should understand, and finally we will come to a conclusion. Yeah, this is just remind us all, what is ethic? Yeah, generally speaking, an ethic is a set of moral values or principles. And what is moral? Moral is as adjective. It's concerned with the principles of right and wrong behavior, or it means holding or manifesting high principles for proper conduct. And then bioethics is a special area of the ethics. Bioethics is the study of ethical, social, and legal issues that arise in biomedicine and biomedical research. Yeah, so it's relevant in medical practice and in the delivery of care to patients. Yeah. In order to understand the public health ethics, we will look first at the ethics in epidemiology, because epidemiology is one of the basic and important practice in public health. Yeah. The ethical principles that arise in epidemiologic practice and research include informed consent, confidentiality, respect for human rights, and scientific integrity. Yeah, so we can see that scientific integrity is added to the principles of ethics as a common definition of ethics. Then ethics in public health means that it could be interpreted many things. Yeah? So like whether that means health is the right of every person in the community. Terus then yeah, it is important to protect the health of population and the individual, and the priorities sometimes is in conflict, yeah, between population and individual, and that's where the public health ethics can help us in the in making a decision. Yeah. This is some example of a challenge in public health ethics. Yeah? That whether we should spend a budget for the elderly or for the kids. Yeah? And then should we force motorcycle driver to use helmets? Yeah? Because then we work against the principles of autonomy. Yeah? We force everybody to use helmet when they drive a motorcycle. And then also disclosing the status of individual. This is in contradiction to the principles of confidentiality, yeah? Of the respect to person, confidentiality. But sometimes for the importance of population, we have to report the health status of individual to the Minister of Health, for instance. The challenge that we have in public health ethics is that we need to improve population health within limited resources. That means that we have to share our resources, and this is a lot of issues in the how we allocate resources here when we have very limited resources. And then protecting individual liberties versus protecting the public goods. Yeah, and I already give you an example using helmets when driving a motorcycle. And now there are many new challenges to the public health. The emerging infectious diseases, bioterrorism, and then we are more and more aware of the social and economic determinants of health disparities, and then still a significant proportion of population without health insurance, and rising costs for medical services. And then on the bioethics side, in order to catch up with the technology development, then bioethics need to be kept mature. Yeah. Then we have key questions, yeah? Whether bioethics can deal with these public health challenges, and And or is there a need for a new set of moral considerations or principles? Yeah. Public health differs from medical care in that public health focus on population health rather than individual, and there is consequently distinctive sets of values here. And we will look that the traditional bioethics may not be sufficient yet to overcome dilemmas that we face in the public health practice. Yeah, in here we compare bioethics with public ethics. The problems that we face in bioethics is, for instance, is end of life and reproductive decision making, then informed consent, emerging technologies, bedside rationing, and clinical research ethics. And we can use to overcome most, if not all, of these problems using the principles of autonomy, beneficence, non-maleficence, and justice. Yeah. And of course, there is addition to that, like fairness and utility. Where in public health ethics, the problems that we have is inequalities in health status. Yeah. So that we have what we call vulnerable populations, and then uninsured, emergence of bioterrorism threats, infectious disease, globalization, health promotion, and cost-effective decision making. Then there is a question whether the bioethics principles is enough to answer public health ethics problem. We will answer that question later. Yeah. So we can see that the moral consideration different between medical care and public health. Yeah. In medical care, the levels of moral consideration is in individuals, while in public health, the moral considerations is at the community or population level. Yeah. In bioethics, the orientation is individual. Yeah. We can see that as example in the informed consent process when we make a decision about the management of the patient. Yeah. And now about it's getting more and more that the decision is shared by the doctors and the patients. Yeah. So used to be doctors who make the decision, but now there's not we involve our patients more and more in the decision making. Yeah. So we come to the era of shared decision making. Yeah, means that the medical practice is not anymore fully paternalistic. Yeah. Yeah. So in bioethics, as the role of individual increases, then physician paternalism face limits. In public health, paternalism often still necessary and justified. So that's the one of the important difference between bioethics and public health ethics. I think because of time, I need to go quickly to the to my slides. You can take a look at that later. We will share it with you. Yeah. Yeah. Okay. Then we before this, we see that in the 2x2 table, there is still blank on the left, on the right lower quadrant of the 2x2 box here. So shows that we need frameworks for ethics for public health. Yeah. So the a few published network for public health ethics is already published. Yeah. The purpose is to make normative issues and moral values explicit, yeah, more and more explicit. So it will be easier to evaluate public health principles and processes, and also look at the balance between individual and population level concerns. Yeah. By framework means that implicit that attention to ethical issues will make for a better public health. Yeah. This is the claim for public health ethics. Yeah. Yeah, as early as 2001, Nancy Cass proposed this ethics framework for public health. Yeah. Just the look at the last three, yeah, whether the burdens can be minimized, and also whether the program implemented fairly. Yeah, we already know these principles. Yeah, in the principles of bioethics. Yeah, and also how can the benefits and burdens of program be fairly balanced? Yeah. So it's like risk benefit ratio in the common bioethics principles. So the common themes of the emerging frameworks is their greatest emphasis on public health benefits or effectiveness, and then consideration of social inequality, social justice, and distributive consequences. Also, fair process. There's now more and more public participation in the public health practice, and then we need transparency and trust. And we have a preference for a least restrictive alternative, yeah, because restriction to the community is would be more difficult than restriction to individual patients. Yeah, the limitation of the framework, there is no clear consensus yet about which framework is most useful in any or if anyone is sufficient, and the framework may not be applicable to the full range of public health ethical issues. So there is no magic bullet to solve public health problem, ethical problems. And then one important thing in the era of evidence-based medicine and evidence-based public health, and then none of these frameworks has been empirically tested yet. So we come to the 2x2 box, yeah, that I showed to you before, yeah. But now we can see that in the right lower box, there's already principles. Yeah, used to be a question mark in that box, but now we can see that we can identify public health ethics, the principles of fairness, population level utility could be understand easily as preference, utility, and then social justice, efficiency and cost, yeah, and also transparency. Yeah. So this is this will be added to the bioethical principles, the 3 or 4 principles, autonomy, beneficence, non-malfeasance, and justice. There's still challenges for public health ethics. We need agreement among diverse stakeholders, which is sometimes very different, and a need for methods to evaluate or measure fairness, utility, etc. Many of the construct in the public health ethics framework is difficult to measure. And then we need to consider political issues and consequences, mechanism for public involvement, move beyond bioterrorism to encompass other moral issues within public health, and balance need for ethical deliberation with timely, effective public health practice. So I come to the conclusion of my talk. Public health ethics requires a new approach, and in this way, we can consider bioethics as a distraction. Mean that we sometimes it is difficult to move from the bioethics. And then further work developing and assessing frameworks is still necessary. These are the references that I use to make this presentation. Okay, thank you very much for your attention. Hope this presentation is of benefit to you. Thank you.
Thank you, Prof. Hakimi, for sharing your expertise and also bringing out the essence of how public ethics is important and it's required, needed. Yet we are aware that there is still gaps or maybe a lot of work in progress about the principles, and also the frameworks is still relatively newer or younger compared to the older, established, and discussed bioethics and medical ethics. So I think this is a really a good start and introduction and emphasis from Professor Hakimi about the bigger question, like how do we move forward about ethics in public health practice, considering the landscape of the society and how the issues, and not just nationally, but also globally. And I think that's why the whole needs of that globalization, ethics, and public health practice is going to make it a lot more compelling for the need to discuss and coming up with discourses about public health ethics principles and framework, as what Prof. Hakimi has mentioned. And Prof. Hakimi will still be with us until the end of the session, so we can collect and discuss together as panel after the next 2 speakers, Prof. Hakimi.
Yes, I would stay.
Okay, thank you. Yeah, thank you, Prof. Hakimi, for staying with us. And so I would like to request kindly to be a bit more patient to our audience. We will straight to our next 2 speakers. And then after that, we will open our main discussion with our 3 panelists and speakers. So I would continue to Dr. Agnes Bhakti Pratiwi. What we are more familiar, we address her as Dr. Tiwi, or maybe Dr. Agnes, but I'm more familiar with Dr. Tiwi. So I'll just address you as Dr. Tiwi. So the committee, please, would you put up the screen for the CV of Dr. Tiwi, so I can introduce briefly to our colleagues at ITMO University. So Dr. Tiwi is later going to be talking about the case study about the situation or the issues, ethical issues in primary care services, which is very closely related to the practice of public health services, because the primary care is closer to the community and with the programs of public health promotions and prevention. And so this is the CV, very short CV of Dr. Tiwi, just for the sake of time and efficiency. So that's why we kind of like concise the introduction, but she has a lot more story than this and than just this one slide. So she's a lecturer at our Department of Medical Education and Bioethics here at Medical School at Gajah Mada, and she is currently a candidate, almost going to lose the candidate because I think she's going to have the title PhD this year, I believe, from Amsterdam University Medical Center. And she's also the member of International Association of Bioethics and also member of Health Systems Global, and also the member of Indonesian Dentist Association and also International AIDS Society. So that's a very short and a glimpse. So we will learn about her further in her talk. So Dr. Tiwi, time is yours. So you have roughly also around 20 minutes.
Thank you, Dr. Wika, for the introduction. I apologize for my voice because I have, I think I got influenza and it is raining heavily here, but I hope, just let me know if my voice is unclear or if it's not loud enough. Welcome to our colleague from ITMO and good morning in Russia, and also selamat siang bagi para Bapak Ibu yang di Jogja. Izinkan saya, please allow me to discuss and to describe a bit of our study and share also the findings. Thank you to Prof. Hakimi for setting a bit the scene about public health, what is ethics, what is public health, and also the ethical principles, which is very important and also interesting to understand further. So I will discuss, I will zoom in a bit of one ethical issue around privacy in primary health care. First, I would like to acknowledge my supervisors. This is part of my PhD study that I'm doing in the Amsterdam University, and Prof. Dick Willems and from Amsterdam University, and also Ibu Retnasiwi Patmawati from UGM are my supervisors. So I would like to start about why we need to look closer at the primary health care and also the related ethical issues. As we all know that primary health care is very important, not only for public health, but also for the universal health coverage that nowadays almost all countries are aiming for. But despite the continuous improvement in the quality of patient-centered care, different challenges still persist. Sorry. Oh, somehow I cannot next. So it has different with the care in the hospital or the higher level. In the primary health care, it is very important how to find the balance of the social and the medical aspects that really meet the needs of the users of the primary health care. And why primary health care? Because primary health care is usually widely available in different countries, also in Indonesia, but it doesn't mean that it will be the preferred choice that the users will want to go. So it is possible that some users just prefer to show up in the emergency department whenever they have symptoms just for convenience, or also to the hospital because maybe they perceive that the quality of care in the hospital is better, or in the context of Indonesia, also sometimes they like to access the traditional healer. So it might not always be a preferred choice. And now I would like to take you to where we virtually are in the city of Yogyakarta. It is in the central of Central Java. Hopefully in the collaboration later, we can also really see you here in Yogyakarta one of the days. And then after going to the city of Yogyakarta, we are now looking a bit to the primary healthcare that we have here. So this is a typical good building, a good primary healthcare building that we have. And in the right side of the picture, you can also see the waiting room. So usually when people access the care, they will have to wait in numbers, so they queue a bit to get the care. And why privacy in the primary health care? Privacy is very important to maintain patient dignity. And the doctors have also the ethical and legal duty to protect patients' privacy. During the care pathway, patients will convey different kind of information to the doctor about their symptoms, about their disease, and also the story of their lives, which usually includes sensitive and also private information to a various extent. So what happens when patient's privacy is violated? It can cause harm to the patient, and it can also affect the patient and doctor relationship. So our aim in the study is to discuss the privacy situation in primary healthcare and how it may affect patients. And we were looking from both the patients and doctor views. So briefly about the method, what we did in-depth interviews and also in observation in the primary healthcare and inductive and thematic data analysis. So this is the participants. We interviewed 45 participants from general practitioner, dentists, primary healthcare staffs, and also primary healthcare users, and also non-primary healthcare users. So briefly, after we look the building from outside of the primary healthcare, now we look inside of a typical primary healthcare building. So these are the typical good primary healthcare building that we have. The setting here in the picture in the left-hand side, where you have the tables, chairs, where the doctors or the nurses can ask the patient question, have some consultation, and then also do the examination until they finished with the prescription or the treatment. So I would like you to look a bit of the setting of the doors here. The doors are open, and also some rooms, they also have curtains as a separation. It's a bit similar to an emergency department setting, a bit similar. So this is the situation, which we will relate later to how it may impact the perception of privacy of the patients and also of the doctors. So in our study, we have 4 themes. The first one is about the physical buildings and context of the primary healthcare that affect patient privacy. The second is how lack of privacy can affect the quality of care. The third one is understanding the meaning and importance of privacy. And the fourth one is perceived privacy protection in the primary healthcare. So I would like to describe briefly each of the themes. The first one is physical building and context of the primary healthcare that affects patient privacy. So as the patient said, like in this primary healthcare, the doors are open, as you could see in the pictures, but no one will snoop around except my wife and child who accompany me. That is all right. Maybe for me, I wouldn't make that as a problem, but this is for me. I will try not to be bothered, so it is okay. But with the open doors, other people present may see or also hear the examination. This also affects the doctors. The doctors sometimes feel uneasy to ask sensitive questions in order to explore more during the anamnesis and also to comfortably perform physical examination. So the doctor said, if I ask about sexual behavior or private matters such as eating habits, I feel that the patients, hold back some information. So they will only provide good answers or say normal things. So this is a barrier for us to diagnose. The second theme was about lack of privacy and how it affects the quality of care. At the primary health care, when patients sense an unsafe and hesitant feeling of their privacy, some of the following gestures have occurred among our study participants. So the first one, patient might lower their voice if it is a secret. So talking like in a very low tone voice, or else they will take an action to deliberately close the door when entering the consultation room, while usually the doors are kept open. Or they will choose to completely hide and not disclose the information, although they might know that it is relevant to their medical condition. So this affects the process of the anamnesis and also the physical examination. As a doctor, also conveyed that how do you perform physical examination? How do you usually do it if there are no curtains? If we remember again the picture that I just show in the beginning. So a doctor said, yeah, physical examination is only minimally performed. We just decide according to the symptoms. And then when it is really necessary for the patient to lie down, we usually move to a treatment room, so to another room. The third theme is about understanding the meaning and importance of privacy. Maybe it is generally known that privacy is important, but we wanted also to know what's really the meaning when they visit the primary health care. So to the patient, it is a secret that other people should not know, including what is inside their medical records. So there are patient concerns around privacy, which is related to avoiding the shame and judgment if a medical condition might be judged unacceptable. The common expectation of good behavior or norms that are related to religion, culture, and tradition. So when patient thinks that what is happening to them doesn't really fit to the norms or the expected situation in the society, they want to keep that as a secret only for them and for the doctors. And also to have some privacy from their neighbors, families, and also people who are close to them. But this is really a challenge in the primary health care because usually it is a health center that is in the neighborhood or nearby where someone lives. So if they access the primary health care, it's usually where they also can meet their neighbors or even their family, the people who live around their neighborhood. And privacy also means that they are able to choose the doctor of the same gender, and particularly when physical examinations are involved. The fourth theme is perceived privacy protection in the primary health care. So our participants says that usually, the privacy protection is okay and it is good. But so they show acceptance in the first time when we asked, but when we dig further, some respondents also say that their experience actually was not satisfactory. So they say that it is not enough because it means other people may know what disease we have, listen what we say. I think every time being examined, the door has to be closed. I mean, if we want to explain something, other people should not know, so we can explain it more comfortably. So here, maybe the patients say it's good, it's okay, because they mainly access the primary health care for mild conditions. And if they have like some medical condition that they think it's really something they wanted to keep private, it's possible that they might not access the primary health care nearby their neighborhood. And how is it for the doctors? They say that they also need privacy so that they can feel comfortable in doing their tasks. They say that, for example, if we have to examine a lump in certain part of the patient's body, we want to examine, but there is no curtain. So we have to move to another room first. And the moving to another room might also mean that there is something serious or something that is not as usual that the doctor finds, because all the other patients will be in the big room where they usually do the consultation and examination. And once there is something more serious or more privacy needed, they will move to another room, which also might raise some curiosity from the people in the waiting room or inside the room. Oh, what is happening? Why are they moving to another room? So before I move to the conclusion, I would also like to reflect a bit of the findings that and discuss it. Firstly, that the situation, the feeling and perceived lack of privacy were mainly related to the physical building and settings of the primary health care in our findings. So it was not so much related to the electronic medical record or the fear if their data will be out in the electronic forms or in the internet or something like that. And also it's about the presence of other people in different ways. So the patients and the doctors feels the need for more room for privacy, although it is not necessarily verbally expressed as a need for privacy. So if the other room are used for specific purposes, to avoid curiosity or stigma, the patients who enter a specific room should not be visible to the rest of the patients who are in the waiting area. And it is possible that privacy in primary healthcare is an issue here, but it might not always be an issue elsewhere, maybe in countries with a more established primary care system. However, in the context of a developing country, or the findings in Indonesia reveal that privacy-sensitive issues are still prevalent in the primary healthcare. If I may connect to Prof. Hakimi also about the raising cost or cost effectiveness in decision-making, where maybe it is possible that the primary healthcare prioritize to serve more people or more members of the community. So they have to balance about the principle of cost effectiveness and also how to balance the privacy. because the situation was that usually in the care, doors are open, people just queue, they just go in and out. So in one day, they could serve, for example, up to 100 patients. And here it's also the questions of what happened if we don't put enough attention to privacy, because it is related also to the principle of non-maleficence or even beneficence in the treatment that we provide to the patient. So in conclusion, I think that privacy should be really placed as a key element in the primary healthcare delivery. Patients and doctors' physical and also informational privacy is essential to creating primary care as the primary source of care that responds to the privacy values of its users. But so far, it has been quite overlooked. So this situation compromised patients and doctor openness to share information and ask questions. Primary healthcare in Indonesia and also in some similar contexts, we found also in Turkey and Pakistan, privacy issues in primary healthcare are still prevalent. And in situations where privacy regulation are not always available in place, they should give attention to the physical privacy needs of patients as well as doctors for a better doctor-patient relationship and also the quality of care profession. We could also infer from this study that the primary healthcare building designs and care profession guidelines should incorporate the privacy needs of patients and doctors. So yeah, this is maybe for further discussion. Maybe we could later share a bit about how the situation is in the context of Russia or in other contexts. And are there some contrast or also some common similarities? And this is the link to the article. And thank you so much for the opportunity. Looking forward to the discussion.
Thank you, Dr. Tiwi, for sharing the study, the result of part of your study. And I think it's really interesting because it's really captured the context of how it is practiced in our country, especially in our city, about the primary healthcare and how it is related to it's going to relate to how public health is practiced in Indonesia, because primary healthcare is one of the venue. But yeah, we will discuss more later. I also would like to discuss about that, but we will wait until our third speaker. And then after that, we can freely discuss the whole thing. And we're just going to straight continue to Prof. Yayi Suryo Prabandari, and I'm also going to introduce Prof. Yayi very briefly before her talk. And so please, the committee, would you please share the CV of Prof. Yayi? And Prof. Yayi is a professor and head of the Department of Health Behavior, Environmental and Social Medicine in our medical school. And she is currently the head of a master's degree in health behavior and promotion, public health science and study program in our Faculty of Medicine. And she is also coordinator in the Quit Tobacco Indonesia. It's an international project, collaborative project about tobacco control, and the coordinator of quality assurance for bioethics master's study program at our university. She's a psychologist, clinical psychologist, and most chairman of the health promoting university at our university, and also member of ethics research ethics committee at our medical school, and also very active, obviously, at our Center for Bioethics and Medical Humanities. So it's a really short and condensed experience of Prof. Yayi, so it's difficult to condense all in one slide, but we will learn more about her in her talk. So Prof. Yayi is going to share her expertise and experience in the area of public health practice, especially tobacco control and smoking cessation. So how ethics issues and ethics principles is applied. So Prof. Yayi, time is yours, roughly around 20 minutes.
Okay, thank you, Dr. Wika, and I would like to share my screen. So how about my voice is already okay? And
Yes, very
also the
clear.
slide, okay.
Yeah.
Because here in my house, yeah, it's also a big rain, but it's already goes to stop. Yeah. Okay, so good morning, our colleague from ITMO, and good afternoon, selamat sore, Bapak Ibu yang dengan sabar menunggu. So, Assalamualaikum warahmatullahi wabarakatuh. So, greeting from Indonesia, and thank you for joining the seminar for today. I will share about the application of bioethic principle in the Indonesian patient to stop smoking. This based on our experience. My colleague and I had a project in the year of 2002 until it is almost 10 years, yeah. 2012, 2013, and we have what we call Quit Tobacco Indonesia, and we have three main activities. First is developing the tobacco-related diseases modules for the medical faculty, then develop a smoking cessation clinic that's collaborated with the provincial and municipality health office, as well as developing smoke-free area, smoke-free home movement in the area of Yogyakarta. But today I will share about the work with the smoking cessation clinic. So this, my outline is definition. I will a little bit remind, not public health, but health promotion. Health promotion is the branch of the public health that the main focus is to trying to promote health on the community. I will give the definition and then evaluate the application of the public health ethics in the case of smoking cessation, and as well as health promotion and also the issues in health promotion. So health promotion, according to the WHO, is the process of enabling people to increase control over and to improve their health. And I took one of the model that we use in the graduate program of public health, majoring in health promotion. One model that the students, when they goes to the field, they should follow this model. So I will also compare with in the medical field. Yeah. So when we trying to develop a health promotion program, this is also a program, one of the brands of the public health. So we need to do a community analysis. It is look like when Dr. TV explained about anamnesis, yeah, proxy to history taking in the individual patient. But this is community analysis. We can do a survey or qualitative study that we ask people with their condition, what about the health problem that they face, yeah, and then we goes to who the target of our intervention. This is targeted assessment. It's look like in the medical field is like a differential diagnosis. So when you trying to find what is the cause and primary cause, we also trying to find who is suffer most or who is related to the health problem, and then which population that we targeted. So in the smoking cessation, we did a survey among the community at the time, and as well as we did also a focus group discussion, as well as the in-depth interview to the community, and then asking about how if we help them to quit smoking for the smoker. Yeah, majority of the smoker is welcome if there is service available. At that time, there is no service available in Yogyakarta, especially. Yeah, in Jakarta, it's already running by one of the hospital. That for the hospital is the lung hospital. Yeah, but the patient is still very limited. So we try to apply in the first. We also working with the lung clinic in Yogyakarta, and then we also scale up to the primary healthcare. Yeah. Then we trying to implement this one, and then we evaluate the implementation of the. But I'm not. My presentation are not like Dr. TV, yeah, that really based on her research, yeah. But I trying to apply it into the, yeah, how this bioethic principle, yeah, is applied into the health promotion. So when I compare to the health promotion and then also disease prevention, yeah. So primary disease prevention is almost similar with primary health promotion, but when health promotion is already done, hopefully we will go to the secondary health promotion, that we raise the quality of life, not only health or healthy condition, but individual quality of life. Then if we goes to the tertiary, this is going to the social change. Yeah, in the primary disease prevention, the primary disease prevention is look like the primary health promotion when the disease is not haven't occurred yet. Yeah, but secondary is we goes to the risk population, or when it is very beginning, the disease already usually based on the screening. Yeah, and then if you already suffer from the disease, it still can prevent for not getting worse or get the complication. This is the tertiary disease prevention. So smoking cessation can be, it's not only in the primary health promotion, but also in the primary disease prevention as well as the secondary disease prevention. Because in the lung clinic, the patient that mostly listen, that they are that suffer most. If they just very little mild cough, so they just okay, I should stop smoking. So can I just reduce? So something like that. So when we trying to develop the smoking cessation clinic, I also become the counselor there in the lung clinic. So we saw the patient, and then yeah, if they not suffer most, so especially the patient from something but not TB, yeah, but TB patient usually they listen to the doctor because usually their cough is already influence their daily life. And then tertiary, sometimes, yeah, when they already in very sick, yeah, or not very sick, it is already suffer from the diseases, and then they should also stop smoking, because stop smoking is not easy effort, yeah, because some of our patient it's trying hard, yeah, and then in Indonesia, what I call is when the people trying to stop smoking, it is very hard because cigarette is very cheap, and they can be sold everywhere. Yeah, even they also can sell singly, yeah, so not one pack, so it's very cheap. And then in Indonesia, smoking sometimes is regarded as the social function. I mean that it can be like when the male gathering, that they usually offer cigarette, as well as in the, for example, wedding. Yeah, in now in urban setting in Yogyakarta is already rare, but still in the rural area, the cigarette is one of the hospitality beside of the food. Yeah. I will introduce the health promotion ethics that's considered the concept of well-being, integrity, and then virtues, as well as the autonomy and responsibility, civility, yeah, civility, sorry, caring and solidarity. And the issues of health promotion regarding the smoking behavior. For example, does a particular approach respect autonomy when the doctor asking, please stop smoking? So the patient can sometimes also, smoking is my choice, doctor. Yeah. Even my friend also say to me, he is a smoker, heavy smoker. When the doctor asks me to stop smoking, I will change the doctor. So not not following the advice, but he tried to go to other doctors that maybe, yeah, it is up to you. You can stop or not. Yeah. But according to our survey, actually already almost 70% of the doctor already asked to stop smoking for the patient, but it is for the patient that usually that already have a disease that related to the tobacco. For example, the heart diseases, and then the diabetic, and then the lung problems, yeah, and then also the hypertension. So the doctor, but for other complaint or other diseases, they usually, if the patient still smoke, they trying to talk about this one. And then does it bring about some benefit? Yeah, in our smoking cessation counseling, or what we call is a brief intervention, we also discuss about the benefit of stop smoking. Yeah, even though the smoker is also sometimes also trying to have a debate, yeah, about the benefit of still smoking. Yeah, and then does it avoid harm? Yeah, if I quit, I feel unwell. This because when you quit smoking, there will be some people that will be they experience of withdrawal symptom, that sometimes it's also a little bit annoying, because it is after they stop, they cough, or they have like a bitter taste in their mouth. So, and then feel a little bit difficult to sleep. That's what the withdrawal symptom that reported to us. And then also, what combination the benefit and harm does produce. This what we asked to the doctor at that time. We had the project to discuss about the combination of the benefit and the, for example, yes, you will experience about withdrawal symptom, but thinking about the future, yeah, if you can stop smoking, yeah, you can have a better to breathe. And then for the young people that I discussed with the patient, this patient is coming to the lung clinic because he like running. So I asked him that, I told him that if you stop smoking, you can run faster, you can run in the easy way, yeah, and you can enjoy running. So this is the benefit. And even though you will experience about withdrawal a few times, yeah, I mean that there is vary between patient to another patient. Yeah, I have a friend that suffer or experience about withdrawal symptom until 1 year, but I had a patient that he just experienced withdrawal only a few days. Yeah, but it depends on how many cigarette that you use or inhale. So this is issue. Another issue is dangerous to our own health. There is a far less agreement on what can or should be done to make people less foolish. In the social media, there are a lot of messages that trying to contrasting about the health effect of quit smoking. Yeah, so there are a lot of fact and myths in the social media. So sometimes, yeah, this is sometimes also endorsed by the cigarette company. Yeah, they now using the what do you call it? The celebrities, not celebrities, that YouTuber or something like that, not showing directly to the cigarette, but show that the cigarette is one of the things that you need in the social life. And where does personal choice and collective responsibility begin? So this is when we try to discuss about the active and passive smoker. Yeah, so we also discuss and we also told the doctor health professional that we working at that time to ask the patient and then to try to discuss about the patient thinking that not only him that suffer from the cigarette, but also in the family. Yeah, because family, if you still smoke inside the house, the family is also influenced by the secondhand smoke. And this is sometimes we need to have the good reason when we discuss with smoker when how we reconcile two or most prized social values, personal freedom and good health. So the issues in health promotion ethic is also what are the appropriate limits of the country, province, or district in liberal society in restricting or prohibiting behaviors that lead to premature morbidity and mortality in shaping, molding, and influence the preferences and desire of a citizen in protecting citizen from the commercial influence. For example, cigarette advertisement that still available or still okay in Indonesia because the government only limited a certain way, but not banning at all. Yeah, a few of districts and also cities now have their own regulation to regulate their smoking advertisement. But on the television, on the social media, we still can see cigarette advertisement. Yeah, because the regulation from the government not banning all, but they have certain regulation. And this is the general framework and practical example, 5 principles of planning and evaluating health promotion. Recognize that health promotion thinking must be responsible to partial things. So because we did the community analysis, so not like generalizable. And then formally recognize and implement 2 iterative system in reasoning, system and ethical system. This sometimes we need to consider, we need to trying to consider about this one, clearly specify the evidential and ethical concept that are values or devalued in each situation and the dimension along with this vary. And be specific about the trade-off of occurring along the identified dimension, consider value and devalued concept interact, and also prioritize procedural transparency, be certain to the process. So I have one of diagram that can be applied in the when we develop intervention, public health intervention, and especially the health promotion intervention. So what is the health promotion situation? How can we reason ethically that we also it is better we also based on the evidence, yeah, based on the health promotion intervention in the past, yeah, but also what ethically relevant concept, and then also this concept what dimension, so which dimension of the ethic that we can apply, and where do we place that dimension. So when we why we do a community analysis, because sometimes public health intervention is like top down. So not asking the people, so do they need, for example, yeah, do they need to quit smoking? Because sometimes it is not the need of the community. So why we do community analysis, so we can discuss with the community, yeah, and then trying to make awareness of them. Then we try to discuss what is the best things that we can apply in this community. So based on the evidence, but also we try to like asking in the bracket autonomy, but this is autonomy from the community. All right, this is the ethical principle of practice of public health. This is very small, but I will show how I try to insert into the smoking cessation. Yeah, but underlying the principle is still bioethic principle, autonomy, beneficence, non-maleficence, and justice, and as well as the public health universal declaration of human rights, that everyone has the right to a standard of living adequate for the health and well-being of himself and his family. So offering people on assisting to quit smoking is provide right to resource that necessary for health. So this is the application of the 12 principles. So when we try to address principally the fundamental causes of diseases and requirement for health, aiming to prevent adverse health outcome. So we need to discuss with the community, yeah, why we should thinking about quit smoking. Yeah, why quit smoking is important. Achieve community health in a way that respect the right of individuals in the community. In our smoke-free home movement, we try to bargain, to discuss. Yeah, for example, okay, you do not need to stop now, but at least you have to smoke outside the house. Yeah, because if you smoke inside the house, that the family can be influenced by your smoke. Yeah, secondhand smoke. Policies, programs, and priorities should be developed and evaluated through processes that involving community members. Yes, we did it when we try to discuss with the community, even when we try to develop the smoke clinic, smoking cessation clinic. We collaborated with the provincial health office as well as the personnel from the primary health care, and also the person that the community leader, as well as in Yogyakarta, there's also women organization in the community. So we discuss with them. Work for the empowerment of the community. Yes, we also, beside we train the health professional in the primary healthcare, we also train the cadre. Health cadre is coming from the community. And then we also trying to build the smoking cessation clinic in the inserting in the primary healthcare. This is like information needed to implement effective policies, and then policies programs should obtain the community consent for the implementation. Yes, we try to do, and then first with the analysis, yeah, community analysis is the last two slides, and a timely manner on the information they have within the resources and mandate given to them by the public. We also give health education to the community, yeah, and then in the primary healthcare, we also distribute some medias, health promotion medias, and we try to also considering about the value of the culture of Yogyakarta, because we in Yogyakarta we make the media and then with the more offering of benefit, because they don't like message like this, smoking kill you. So Yogyakartanis, they don't like it. So we try to develop media. Then media is also used in the smoking cessation clinic, and also enhance physical and social environment. Yes, this is attached to primary healthcare, because primary healthcare, the community usually first, and in our health insurance system, the first they have to go to the primary healthcare. And we also train the health professionals, the professional competence of their employee, and then collaboration and affiliation in ways that build the public trust and institution effectiveness. So in conclusion, the application of public health ethics in smoking cessation has been applied, although needs improvement. Discuss about the right of smoking or not smoking remains obscure. Yes, the doctors that in the focus group discussion, they also raised this one. But health professionals can discuss on the risk and benefit, trying to challenge the personal freedom or good health. Thank you very much. I return back to Dr. Wika.
Thank you so much, Prof. Yai, for sharing your expertise and also practices through the project or the movement intervention for tobacco control, and especially smoking cessation in primary healthcare, because that's also like a huge part how the smoking cessation is really heavily affected by the national policy, national commitment about tobacco control, because otherwise the practitioners, doctors, finds it difficult to model or to advise on the patient's change of behavior, because there's other distraction. But yeah, the example of the project that Prof. Yayi mentioned about the ethical aspect that is have been put in the effort to involve the community and how to consider the value, the local values, so that it can add on to the beneficial and the sustainability of the intervention. So I think that's also one of the highlights of Prof. Yayi's talk. Thank you, Prof. Yayi, and also thank you for Dr. Tiwi and Prof. Hakimi for still staying with us. So now I would like to open directly to the discussion. I'm aware that we have very limited time left because we started rather late, and but I think we still have time for discussion. So I would like to invite if there's any comment or if there's any questions already shared in the chat box, then I think we can go with whichever comes first. So I would like to provide the opportunity for the audience now. And I would also greet the audience in Bahasa. So I apologize that I only going to greet the audience in Indonesia, in Jogja now, in Bahasa, but we can still do the discussion bilingual. So I will help bridge the communication between Bahasa and English. Bapak dan Ibu, kami persilahkan untuk yang memiliki komentar, tanggapan, atau mungkin hal yang ingin diklarifikasi dan ingin didiskusikan langsung dengan para panelis kita. Kini masih berada bersama kita, Dr. Tiwi dan juga Prof. Yayi. Jadi tema hari ini kita bicara tentang public health ethics, importance, principle, dan beberapa contoh praktis yang kita sudah lakukan di Indonesia, di setting kita. Kami persilahkan. Apabila ada yang ingin berkomentar langsung raise hand. Oh yeah, so we have one volunteers or Bagas, Mas Bagas, Dr. Bagas. Yeah, salam kenal. So yeah, you can open your mic if you would like to speak
Right.
directly. Yeah, so you can
Thank
use
you.
either Bahasa or English, but I think you're going to use English. So please.
Right. Thank you, Mbak Wika. Good morning, everyone. I would like to ask a question for Mbak Tiwi. So when you try to show that privacy is indeed one of the concern here in the public or primary healthcare setting, I would like to know if the concern also came from like a certain family with certain background, or perhaps it's more from the healthcare professionals who feel that they should be able to provide more privacy. I mean, I would like to know which is like the source of this privacy concern. And the second, maybe I would like to ask to Prof. Yayi. So regarding the intervention that would be implemented by the public healthcare or Puskesmas, sometimes I also think that they already have like so many programs from the government, and sometimes we as a scholar would like to have some idea to implement certain program that we think would be also a valid concern, but we think that Puskesmas has already get so many burden. So I would like to know how to balance to make it as a balance between these different roles and obligations within the Puskesmas jurisdiction. I think that would be all. Thank you for the opportunity.
Thank you, Mas Bagas, for the question. So one is for Dr. Tiwi and one is for Prof. Yayi. Dr. Tiwi would like to straight to the answer, responding that.
Yep. Okay. Thank you, Mas Bagas, for the question. And nice to see you again, although online, because sometimes we also meet in the other side in the Netherlands, in the department. Yeah, so the question was the source of concern for privacy and from whom was it? So it's from, so you asked whether it's from the family, from the patient, or also from the doctor. So as I know from from our findings from the doctors, they had an uncomfortable feeling related to privacy, although it was not implicit. And then when we came and asked about and bring in the term privacy, they start to think about what's their privacy concern. And we know from them that first, the privacy was acknowledged as a value explicitly in the primary healthcare when there was accreditation. So when there was a body who I don't know who assessed the accreditation to mark whether a primary healthcare meets certain qualification and quality. When they came to assess that, there was actually a point about privacy. And because it came in, the doctors and the primary care managers start to think about it and try to do something in the privacy, but it was mainly to fill in what is needed for the accreditation. But then they also feel that without the privacy for the doctors, it is difficult or it is a challenge to do the anamnesis to get closer to the diagnosis, because in the primary healthcare it's really different, where patient might present with all kind of symptoms, and it's not always easy for the primary care doctors to move closer and to have a fixed diagnosis. So it is a challenge for them to collect more information, although there's also time constraint that they say it's also a constraint why they don't ask further questions. Then for the patient, it is mainly their consideration that in the beginning, when they came in the information in where they have to put their, so first you come in and then you have the what that front office desk, something like that. They already asked there, what symptoms do you have? What disease do you have? And then next they are having the vital sign examination, also asked, what disease do you have? And this is like in a space where maybe other people present. And then also in when they meet the doctor, probably the doctor already have some information, but incomplete information. It is possible that the doctor asks again, or they already just read from the information that they already have from the nurses or from the front office. So that was the issue. And for the family, there was also an issue of some sensitive medical condition like tuberculosis, where this patient is not examined inside the primary health care, but outside, because they don't want the contamination. So this patient stays outside, and of course it's in the community, then it will raise question, what happened to this patient? Why is he staying outside? And also like for issues like HIV, it's very a very sensitive case. And sometimes the family will come because they don't want the patient to come. And then maybe the neighbor or the community will see the patient. So it's actually concern of mainly all of the stakeholders in the primary healthcare. But I think it was it's not yet explicitly seen as a source of concern that needs to improvement.
Okay, thank you, Dr. for the response. Mas Bagas, would you like to have another response to that answer from Dr. Tiwi?
Oh, no, I think I'm very interested in the concluding remarks from Mbak Tiwi that the concern is from everywhere, but it's not that explicit and very strong.
Until the research, until the research, like everybody knows that it happens every day, but then after that, then they get to explicitly state that it is actually a concern. Yes. Okay.
Right.
Yeah, thank you. So I will like to invite Prof. Yayi to respond to the second question of Mas Bagas. It's about how to balance, how to balance given the duty that is already a lot, the workload of the practitioners at the primary healthcare, but then again about the maybe the smoking cessation, also maybe other programs that is also put on the shoulders of the primary healthcare practitioners.
Okay, thank you. Thank you, Dr. Vika. Thank you, Mas Bagas, for your question. For the smoking cessation, at the time we implemented the program, actually those intervention is in line with what they call healthy and clean behavior, PHBS, because in one indicator in the this movement, gerakan Kermas and PHBS, it is the number of person who are smoker inside the house. So this is our smoke-free home movement. Yeah, at that time we also trying to ask them to join us, and then usually because this is also the daily activities for the health promotion personnel, and Puskesmas, I also trying to explain to our colleague in ITMO, in primary healthcare in Indonesia, there are a variety of health professionals that working in the primary healthcare, not only the doctors, but also midwives, nurses, health promotion officers, and then health environmental officers, as well as the sometimes they have nutrition, and in Yogyakarta especially they also have the psychologists. Yeah, so I also train the psychologists for the especially for the heavy smoker, that they can deal with it. But for the smoker, they can go to the doctor. The doctor, we try to have the not for all the steps of the brief intervention should be done by the doctors, but we divide it. So which one is the doctor do it? So for example, because we apply 5A for the ask, advise, and then assess, assist, and then arrange. So the doctor is only for the ask and advise, because I know that in Puskesmas, in primary healthcare, the doctors only have 5 minutes. This is it's very good if 5 minutes to see the patient. Yeah, but within the 5 minutes, but educate with the very short. Yeah, and then the others is coming to, because they have clinic PHBS. So for the healthy and health behavior, yeah, they have the clinic, especially not only for smoking, but also for the physical activity, and then for the eat well. So they can put into that one. So what should the scholars or maybe the doctors that still doing their internship in the primary healthcare? First is like doing the analysis first, or just talking with the health professional in the Puskesmas. Yeah, what programs that we can help assist. So you are not adding, but the scholars can give another strategy. Yeah, still within the programs that coming from government, because the program, yes, is already many, yeah, but sometimes they're not this program not running well, so it needs assisting from the scholars, yeah, how to make this program can running well. So my recommendation is not adding the new one, as well as when we try to inserting the smoking cessation, at that time is related with the PHBS, yeah, with the healthy and clean behavior. And then just before we ended our project, the government changed, and the changing is more related to the smoking cessation, because now the indicator of PISPK is there is no smoker in the household. Not only smoking inside the house, but there is no smoker in the family. When this indicators is already applied, I have friend in Ministry of Health. So are you sure this is for the indicator? This is the very hard indicators that the primary healthcare should achieve, yeah, because asking people to stop smoking is not easy way, but they try to do it. Nah, your or the young generation from the scholars that they can also help it how to make this community trying to apply this healthy behavior. I think this will helpful. And then for the personnel in the puskesmas or a primary healthcare, when you already apply and then succeed, just not train them, involving them so they can learn. So learn each other. Yeah, I think for the balancing working in the primary healthcare, don't do very new things, but the new is the strategy, how to scale up or how to making the program running well. So the young people usually have a very good idea, yeah, how to involving community, how to involve the young people. So sometimes the puskesmas is already very heavy or very heavy duty. So for thinking about innovative or creative things, they don't have time. So just assisting them about this one. Okay, thank you. Yeah.
Thank you, Prof. Yayi, for responding and answering. So the key is to integrate, to build on something that's already been there, that is already existing in the system, because otherwise it will not succeed, it would not sustain. And also it answers the question how to balance or how to make it less burdensome for the practitioners. Yeah, and also I think Prof. Yayi highlight about the national commitment or policy regulation. It's definitely going to affect the practice in daily, how it is practiced and how it is targeted to achieve. So I think at least that's in our context in Indonesia, how it's really common practices. It's going to be more enforced if it's already there's regulation on top, like a top down is still, but I guess Prof. Yayi is advocating that top down is not always ethical. So, but we also need to do the efforts like a bottom up, how to empower the community and involve them, the local values and stuff like that. Okay, thank you for the answers and also the questions, Mas Bagas. And I'm afraid we're very short on time, but I would like to just give, if there is any comments or questions, anything from our ITMO counterpart, if there is anything that you would like to say at the end of this webinar. After that, then we will go to the closing remarks from each of our panels. Maybe not yet, or is there any raised hand that I haven't seen, or maybe if there's any chat, I'm going to check with also the committee. Is there any chat that we need to go through? Questions?
There is one chat from from apa?
Oh yeah, okay.
From maybe.
Oh yeah, I think this is from Artemi, if I'm not mistaken. Yeah. So Artemi is asking about or commenting. I think it's a huge and unrecognized problem in Russia about the privacy in primary care. Yeah, so it is a comment related to what Dr. Tiwi is presenting about privacy in primary care, and it is also a huge and under-recognized problem in Russia. In some healthcare centers in Russia, consultations are now audio recorded by state authorities, which is a huge breach of privacy and threat to patient-physician trust. Wow, that's another information for us. So we learned as well that so it is mandated that if it is state authorities mandated the audio recording of the session. So it's not in the written medical record, but it's also audio recorded. Oh yeah. Yes. Well, that's news to us because we don't have such context. Like the electronic medical record is already like issues here, but not about the audio recording. So I don't know if there's anyone from the ITMO University would like to comment further about that, maybe briefly.
I think I may comment.
Oh yeah, sure.
My name is Nika. My name is Nika. I'm from St. Petersburg, and these audio recordings about Artemy has said is something new for us. Also, it's right now only in Moscow, and we think it's something about AI, artificial intelligence, to understand this discussion, patients and doctors. But really the problem is that patient, I think, and we have discussed it earlier, that it's really harder for patients to believe their doctors, to say something really personal and something that may have problems on the governmental level. So it's really so we do not expect improvement from these audio recordings.
Oh yeah. So has this been implemented for long? I mean, has there a study about how actually like it is a perspective of the physician or the comments or the response from the patients in Russia about that?
It's really new, and
It's okay.
I think it's just started from this year, 2024, and patients has been divided for two categories. One third that it's so it will disrupt their privacy, and other patients think that it's a good idea because some doctors are rude, and now they have an instrument to
complain.
Yeah.
Oh wow. So it gets to another problem, maybe like a legal problem, legal issues in services, then if the patient goes on to sue the physician. Yeah. Okay, thank you, Nika, for providing more context about that situation in Russia, and we really do hope that we can learn further more about what is the context, maybe in public health practice in Russia. I think we will be able to do that in the next series of our collaboration. And I think because we're very short on time, so I would like to go back to our three panelists for closing remarks, and maybe to help also put together the message that we have already discussed today. I think like in general, it comes back to the discussion or the question that Prof. Hakimi have started in the beginning or in the last slide of Prof. Hakimi's slide about how it is different between the ethics in public health practice and also the perspective that ethics in clinical practice. Because like the ethics and medical ethics really tend to focus on how the individuals, and so including privacy. So maybe if you could comment on how it is in public health practice, can we justify or defend or put it in place about maybe like privacy? Because that's individual. That's individual rights, or that's individual aspects of patients or individual member of society. Considering what Prof. Hakimi mentioned, that if we have public health ethics principles, then the priority would be different, because then bioethics or medical ethics puts more weight on the individual rights. So Prof. Hakimi mentioned, is it a distraction or it is a common tension in public health practice? The ethical tension is between the individual and the community, the collective. So I don't know if Prof. Hakimi can also comment further about that as the closing remarks, and then Mbak Tiwi also can comment about that, and Prof. Yayi. That would be, I think, the sum up for our session today. Prof. Hakimi, would you like to start addressing the closing remark?
I'm sorry, Dr. Wika, I don't have any comments on that matter.
about the distraction. So Prof. Hakimi, would you think like we need to how to balance that about the community and the individual issues about maybe a certain individuals that needs to be defended about privacy in public health practice?
I'm really sorry. I didn't get the questions.
Yeah, Prof. Hakimi mentioned about how bioethics can be a tension, can make conflict between the medical ethics principles and also the public health ethics principles because
Okay.
because the point of view is
Yeah.
different between individuals and community.
I look at general comments.
Yeah, general comments.
Medical ethics generally applies to individual interactions between physicians and patients. Conversely, public health ethics typically applies to interactions between an agency or institution and a community or population. So while public health ethics is concerned primarily with the health of the public, bioethics, sometimes referred to as medical ethics, looks at how a decision impacts the well-being of the individual. Bioethics uses the principles of autonomy, justice, beneficence, or good intention, and non-maleficence, or do no harm. In public health ethics, we should add the following principles into those bioethic principles. And the addition is about fairness. It's more or less like justice. And then population level utility. Again, utility is simply preference. So the preference of the population, but the outcome that we will get, and then social justice, efficiency or cost effectiveness, and the last one is about transparency. Okay, that's
Okay.
my simply.
Yeah, thank you, Prof. Hakimi, for the general comments. So I think the common bridge or principles about bioethics or medical ethics, public health ethics, I think lies in the beneficence and how the utility for both individuals and the community, like what Prof. Hakimi mentioned. And I think in Hakimi's slide also mentioned like the one of the principles is also like even if it might be paternalistic in public health ethics principles, then it should also to be made least restrictive as possible, I think. So I think that part is also caters to it's possible, then it should be least restrictive. But if it's not, then for the good of the society, then somehow it can be justified for a temporary period of time. Thank you, Prof. Hakimi. And Dr. Tiwi, would you like to give closing final remarks for your side?
Thank you, Dr. Vika. Thank you for the discussion and the insight from Prof. Hakimi and Prof. Yayi and the discussion from the participants. So I think it's really important to make explicit what Prof. Hakimi said, the ethical principles, but it is also as important as making it explicit also to make justice about what we mean by it. For example, we want to do beneficence in the primary healthcare, but what do we mean by it? Is it serving more people? Like Prof. Yayi said, 1 patient, 5 minutes, and then we can serve 100 patients in 1 day. Or do we mean by it providing a high quality of care, that we really spend time for the patient, for example, 15 minutes, and then provide more privacy in the buildings and in the setting and in how the healthcare workers work. But I think in the healthcare system, everything is mixed up. You want to provide beneficence for the patient, the best care that is patient-centered, but you want also to provide cost effectiveness. And we should make, I think we should make a priority. If you already achieve beneficence, then we can talk about cost effectiveness. But the reality is, you talk about cost effectiveness and then the privacy, the beneficence, the non-maleficence, the autonomy falls somewhere in between there. So I think it's really important to look again at the situation in the field and then make priority of it. And as we also learned that even one issue, privacy, the issue is really different. In the developing countries, we see how the issue is during access of the care. But in Russia, we see that it is more of the information that might go elsewhere, or that someone else might have access to the information. So even one ethical issue is like really broad, and every context has its different issue that we have to discuss. I think that was my take home from this discussion.
Thank you, Mbak Dewi, for continuing on that and building on that remark from Prof. Hakimi. And Prof. Yayi, would you like to continue and also be the final closing remark?
Yes, thank you, Dr. Wika, for the case of the smoking in the country that smoking is still high prevalence. So applying the bioethics into the smoking cessation consultation or clinic is challenging, but I challenge for the health professionals to discuss about this is personal freedom or this is for the good public good for the health of the second many of the health of the population. So sometimes we try to apply the public health ethics in a certain situation, like Prof. Hakimi said, yeah, but sometimes in Indonesia that I see, sometimes people should be forced to do something. So in the very gentle way, sometimes cannot be applied. So we use the a little bit force like regulation and the policy, yeah, to make the people stop smoking. Yeah, and then this is in the shape of the public goods, yeah, I think, then the autonomy of the personal freedom. Thank you.
Thank you, Prof. Yayi, for making the final remark from your side, especially from the practice of tobacco control or smoking cessation. And I think that's it for our session for this afternoon. And we are really thankful for all three speakers for sharing your expertise and also your experience. And so we are so thankful for our counterpart from ITMO University for staying with us and also discussion with us, and also our audience from Indonesia for participating in this discussion. And we do hope that this will continue, and we are going to plan for another series in collaboration with ITMO. And so then we will more about different contexts from what we have here. And I think that's going to enrich bioethics and public health ethics discourses. And then I think that's going to be beneficial for both our parts. I think that's the conclusion. I'm not going to make any further summary. And before we conclude the session, I don't know if there is any information from the committee that needs to be shared here before we close the webinar. Any information from the committee, or maybe not yet? Okay, if not, then I think we can wrap up the session today. Thank you for everyone joining, and further information about activities from our center and maybe also regarding the next schedule for our collaborations with ITMO, we will share and post that in our website and also in our social media. And if you would like also to put your attendance in the form, then it will enable us to communicate further about our future activities. Thank you for everybody's attention and participation today. Wish everyone is healthy and have a great day. Have a great evening for us in Indonesia. Have a good day for our friends in ITNO, Russia, and see you next time.
Thank you very much for let us join in to your session. It was very, very interesting.
Thank you. So I'll take my leave. Bye.
Thank you, Irina. So